So I was walking around downtown this summer with my two boys, and we happened to stumble upon a candy store. Predictably, we ended up in the store, and as I was trying to avoid leaving with an oversized sucker, or even without my 2-year-old eating his third piece of candy before we left, I happened to witness another family in a similar situation. A young boy walked into the candy store with his dad, and just like my two little minions, he was bedazzled by the array of treats. Frantically, the boy ran around the store, his eyes moving from one shelf to another, but all the options looked so good, and he couldn't make a decision. Meanwhile, his father was becoming noticeably impatient. I'm sure you can imagine what he was looking like, kind of shaking his head, trouncing around the aisle. And eventually the dad had enough. He grabbed his son by the hand, and they walked out of the store empty-handed. As you might expect, the boy had tears in his eyes, and what happened is he wanted all of the candy, and he ended up with nothing because he couldn't choose just one. Well, the reality is we're all that boy in one way or another, and the world is that candy store. We have a myriad of options available to us, but if we don't make a decision about our career, our education, our relationships, our investments, the church we go to, or other important issues, we end up empty-handed. The bigger danger is that we make no decision at all and end up going nowhere and doing nothing. Now, maybe not quite so bad. Sometimes we end up worrying about making the wrong choice. And, what if we regret the direction we take and it's too late to go back? So if you see this quote here by Harry Beckwith is a nice example. People do not look to make a superior choice. They want to avoid making a bad choice. And frequently the injured workers and the families we work with are faced with choices, and they approach these in various ways and experience various outcomes. At the point where discharge from acute rehab is imminent, they're considering everything from medication changes, a new wheelchair, or whether or not to have that next procedure. Regardless, everything seems like a big decision to them. But beyond hour by hour and day-to-day decisions, one of the biggest decisions at this point is what's next. Many times, these injured workers and their families have choices about where they go, such as local rehab hospitals, whether it be outpatient or post-acute, local post-acute providers, centers of excellence around the country, or even home. There are some cases where the choice is obvious and the options are limited. We see this all the time with our families who simply cannot care for their loved ones at the point where acute rehab is coming to an end. They have no other option but to consider another option besides home. In this same category, we've all had the family who just gets it. More rehab means a better outcome, and they're determined to find the best place no matter what. I would consider these the slam dunk. On the other end of the spectrum, there are individuals who are resolved to go home regardless of the circumstances. In fact, post-acute rehab may not be the best next step. Or worst case scenario, they simply will not entertain the idea, no matter what. Either way, anything besides home is a long shot. And in the middle, we have this group of individuals who are on the fence. Their decision is not so clear, and there are many variables to consider. Switching gears a bit, let's consider the work comp industry as a whole, and I'm considering folks like you on the other end of here. My estimation is that a small percentage, if given the opportunity, would passionately attempt to influence a decision towards a post-hospital setting like QLI. If it were your loved one, assuming the situation makes sense, I'm likely you'd abdicate to the best of your ability. And you can't imagine a rehab journey without the best providers being involved regardless of the location. That's the first group. It's likely a relatively small group. There are others who see the value, but it's quite situational, and this is pretty understandable. As the other group, they consider the severity of injury, social or economic factors, convenience, and even their familiarity with the organizations that they've worked with before. In general, these folks are open to the idea, but the circumstances of the situation have a more profound effect on the decision to pursue different providers along the way. Now, there's still a third group. They might be unfamiliar with the options. This is fine, and hopefully those folks are tuning in today. And alternatively, there may be some who are in a routine of doing what's comfortable and familiar with less consideration for circumstances. This is okay too. I'm sure there are plenty of success stories to justify this approach. Now, admittedly, this presentation will likely have the biggest impact for the individuals who are on the fence. But to be clear, post-hospital rehab is not for everyone. We get that. I also recognize there are limitations when it comes to directing care, family dynamics, and other factors that are unavoidable. These situations are complex, but that's no excuse either. Whether it's the client or the medical professional, the wide gulf between those who understand and are passionate and those who are indifferent doesn't work. Understanding the value requires a clear vision and industry knowledge in order to rebuild a life effectively. Closing the gap in understanding of the value of post-hospital rehab and inspiring you to take full advantage of the opportunity you have to impact lives is really the purpose of today's presentation. So let's take a quick moment to get on the same page. And forgive me if I'm starting with some of the very basics, but there are plenty of terms thrown out when it comes to when someone leaves the hospital setting. So things like post-acute, subacute, acute rehab, supported living, I'm sure we've heard them all. And then there are even outpatient and day programs. And so for today's discussion, we're talking in very general terms. And so after acute rehab, people don't understand that we're not in competition with acute rehab. In essence, we're the next step. And for today, we're going to focus on programs specializing in brain and or spinal cord injury. And we're also talking about programs that offer an intensive rehab programming, as well as an inpatient and residential rehab setting. So we're not talking about outpatient, and we're not talking about simply day programs. And so this is pretty typical across the board, but again, you're going to find some programs that have some subtle nuances. And so the problem is that the post-hospital rehab world is so varied. The service delivery model, the outcomes, the aptitudes of the program, and the resources available all differ from provider to provider. So this makes my job difficult as a presenter, and it's hard to make absolute statements about the industry. And just as importantly, this makes your jobs difficult. You're trying to provide patients, clients, and their families with resources to make the best decisions. So we're kind of in this boat together. Fancy marketing materials with elaborate industry jargon, crisp photography, and lofty claims of excellence are easy to come by. In fact, you may be thinking the same thing about this presentation deck, and I wouldn't blame you. The purpose is to paint a clear picture of what could be, and it's well intended by the marketing materials that we often see. But only through experience do we have the opportunity to understand what is when it comes to the strengths and weaknesses of the providers that we work with. This guides our decision making on a more long-term basis. And with that said, service delivery is where an organization shows its true colors. And it's essentially the combination of the treatment model and the processes in place to execute the therapy plan. So as you might expect, when it comes to injuries that we're talking about today, the brain injury, spinal cord injury population, the process is quite a bit more complex than your run-of-the-mill outpatient procedure. And so the concept of rebuilding lives is a combination of art and science. And as you'll see here, great outcomes depend on a good program design. So we've already alluded to the fact that this is the case, and it should take into consideration a few things. Therapeutic intensity and complexity, the environment or environments that therapy takes place in, and the transitions that occur throughout a continuum of care, or through the transitions that happen from start to finish along the way. And so before we dive in too much further, let's discuss a couple models that I'm sure you guys are all familiar with. First, biomedical. And so according to this model, health constitutes the freedom from disease, pain, or defect, making the normal human condition healthy. Essentially, this model focuses on the physical processes only, and it doesn't take into account many of the social or emotional factors and the subjective pieces of the puzzle. On the flip side, we have the biopsychosocial model. This model has really taken off over the past several years, and it's really a more broad view at the individual, and it attributes outcomes to the intricate and variable interaction of the biological, psychological, and social factors, as the word might suggest. So this comparison of these two models is really one of the first major differentiators between a traditional acute rehab, or even a more traditional post-acute rehab program, and a really good post-hospital program. It's really where the art and the science of rehab begin to intersect. And great programs really get this, and they execute it at a high level. If you type post-acute rehab into your browser, I'm guessing you're going to get a lot of different things. But when I did it, there are pages and pages of provider websites that pop up. And after looking through several of them, I noticed there's, again, a wide range. And we classify post-acute rehabilitation anywhere from inpatient facility to home health services. And so there's really no specific definition to identify post-acute rehab. And as providers, I'm sure we have a lot of leeway when we decide what services we provide under this label. Now, one common thing I did notice is that among these definitions was that post-acute rehab is pretty clearly considered to be a step down and much less intensive compared to acute rehab. And admittedly, I've made the same mistake of assuming it to be less intense, simply because the rehab that happens in a hospital, is certainly intense in its own way. I suppose my view is based a little bit based on how the process works for, other injuries, such as an orthopedic injury, for example. Acute care in these situations is relatively intense. And then, once someone becomes more medically stable, there's no longer the need for that round-the-clock care. And an individual can start to manage his or her own recovery process with an a decreasing support from the healthcare professionals surrounding them. So, I think this view is also reinforced by the fact that post-acute rehab is much less expensive than hospital care. And of course, there's no way something could be less expensive and more intense, right? Well, there's more to come on this as well. We find that nearly everyone in our industry expects post-acute rehab facilities to be a step down. Again, I've already mentioned that. But the definition of acute rehab doesn't include anything about intensity. If you look at it, it's really just short-term, immediate care. It's just the beginning of the rehab process. It's a critically important part of the rehab process, but it's just the foundation. It's like building a house. When we build a house, we pour the foundation and we frame it, and we hand it over to the homeowner to figure out the rest. Building the rest of the house is incredibly complex. I know for us and many of you, I'm sure that comes with picking out your appliances and the lights that you want and the paint colors. For us, we moved into our home and repainted it 3 years later. So we've all been in that boat. And this process beyond laying the foundation takes way more time. There's no doubt the acute rehab process is essential, but the foundation of recovery, but the post-acute rehab process should be the most intensive part of the process throughout the continuum. And in fact, it should be a step up in the process. So it just makes sense that post-acute rehab should be a step up, right? Because as medical intensity goes down and hospital level of care is no longer necessary, we can start to begin increasing the therapeutic intensity. And as medical stability, endurance, and strength improve, the intensity of therapy should be higher in both frequency and duration. All too often, it's assumed that the individuals with support of their families can navigate their own recovery once they're medically stable. This is certainly true for most other injuries, as we've already discussed, but we even see folks who are emotionally fit, they have terrific family support, and a pretty steady and positive recovery struggle in this area. And some of them even do well, but this is certainly not the norm. For the population we're serving, it's likely not that simple. It's more likely that an individual may be medically stable and even have some of the qualities and the resources I've listed above, but they need increasing support to effectively facilitate recovery. Based on billing and scheduling constraints, it's easier to use our immediate surrounding, such as an office or therapy room, to provide rehab. But this sterile setting isn't anything like the real world. And so the generalization of skills is challenging, if not impossible, for many individuals. And uh, we see that quite a bit in folks with brain injury as well as spinal cord injury. And rehab out of this context in the real world is rarely motivating, and it doesn't allow us to discover the barriers that may interfere with someone's success. So instead, effective therapy should be done in the context of intrinsically motivating real life tasks and provide really functional environments. And so this means not using or not basing many of the therapies in more sterile therapy rooms or institutional type settings. So, with a little creativity and access to some technology, these real world environments can provide a place where all of the rehab happens, and our clients can really have a higher level of engagement throughout the process. This way, we don't focus on those abstract generalization skills in order to make sure that we have good outcomes. With the Super Bowl really quickly approaching, I also think about it in the terms of a sports team. So take whoever lands in the Super Bowl, whoever your favorite team is, and I'm guessing that those coaches are going to do their best to simulate everything that's going to happen from the time they show up in the city where the Super Bowl is played all the way through everything that happens at the game. And so it wouldn't make sense to practice something that they're not going to experience on game day. In a lot of ways, this is what we're attempting to do when we talk about functional and meaningful settings. It's something that means something to these individuals. We don't have to manufacture the level of engagement. And at the end of the day, they can perform on their own game day, which really is when they go home. So no matter how persuasive we are, a sterile office really can't trump the quad rugby court, no matter how hard we try in order to make that happen. But we have to look back at the model that we're using as well. And is a model that addresses medical, physical, and cognitive recovery enough? Hopefully by now you're starting to gather that that's not the case. If we were going to do that, that would be landing more in the biomedical model discussion. What about the emotional aspects of recovery and the social aspects of recovery, or even the fact that these are typically barriers to recovery? What if instead of treating just the brain injury or the spinal cord injury, we were treating the person who has the brain injury? And in the process of treating this person, we acknowledge that certain aspects of their life may or may not be more important to them. And in doing so, this leads us to better address the social and the emotional aspects of their life. And not only as part of the clinical model, but it's the most important aspect of the clinical model. And at the end of the day, this is really hard to do in a hospital or an acute setting where the medical needs are urgent and they typically trump all of their other things, as they should. But at the post-acute level, this is much different. When an individual is relatively medically stable, this approach is certainly doable. It's definitely more complicated, but it's possible. And so forgive me if this sounds a little bit fluffy, but it is usually the emotional and social factors that determine someone's success and or their failure. It's something that we see time and time again upon discharge or even within our program. Folks, interacting and not being able to cope with some of the challenges that arise with injuries like this. And we've already talked about our goal. The goal should be to help our clients rebuild a life that they look forward to living. And rebuilding a life is a really complex thing, and it's the ultimate rehab challenge. Now, unfortunately, we don't have a crystal ball to predict the future. The extent of recovery or the barriers that lie ahead are certainly unknown throughout this process. And it's easy to restrict our rehab to the here and now and to neglect planning for the, beyond the immediate future. And we leave the rest typically to the next provider or the family to figure out. And what really our job is to dream for these individuals and for their families. By the time folks reach the post-hospital phase, we have plenty of cues and plenty of information that can give us the opportunity to cast a pretty clear vision for success without creating a sense of false hope. So thinking beyond traditional therapy strategies that focus on improving someone's ability to walk and talk is critical. We must be intentional and focus on how to get our clients back on a life path that would account for their previous roles or even their new role within their family or even their community or even hopefully back to work. And so we must be willing to think beyond the next few weeks or months. And we have to consider this individual's life 5, 10, or even 30 years from now. For us, we get a lot of individuals who are still pretty young, and these folks in their 20s and 30s can be the most challenging because even without an injury, it's really hard to envision what someone's life looks like beyond their teens, 20s, and 30s. And so if we're serving this young adult and we don't consider their future 10 to 20 years from now, we may inadvertently restrict them from a whole world of possibility. You know, this often manifests itself with that quick and maybe safe or easy decision just to send this individual back home with their parents. And if you really think about it, you know, no 20-year-old really dreams about living with his or her parents the rest of her life. And, you know, if we were willing to dream for this person or even help this person dream for him or herself, you know, maybe school or even a career and eventually a family or a role in the community could be a possibility. You know, put simply, we cannot awaken the possibility in our clients and their support systems if they have nothing to keep fighting for. And so, you know, we really work hard to help these individuals find their purpose, which is often lost. And it's our job to help facilitate that. One more quick thing on transitions. You know, throughout this continuum of care, there are transitions throughout the process, right? Even in the acute rehab hospital, a transition from a different room or a different floor can lead to some confusion. The transition from acute rehab, hopefully to a post-hospital setting, also can lead to some confusion or some challenges. And then certainly the transition from acute rehab to home is a big jump. And all along the way, those transitions we find are failure points, and they have to be addressed on the front end and the back end. So, you know, the programs that you all are working with should be addressing them on the way in and the way out, and it should be pretty detailed and hopefully down to a bit of a science when it comes to the process that happens there. Let's talk a little bit about costs. So, you know, why use less hospital care? Because, you know, at the end of the day, you can get more rehab for a fraction of the cost at the post-hospital level. You know, the average daily cost of acute care is over $8,000 per day. And so, you know, it's no wonder that we have insurance companies pushing and eager to decrease lengths of stay at this level of care. And honestly, the same principle applies to the acute rehab, the LTAC units, and things like that. On the flip side, you know, the average cost of a hospital-based post-acute program is about $2,200 a day, and so it's a quarter of the cost. And in general, you get more for your money. And so for us, this is our roughly average cost per day, and you know, we're pretty competitive when it comes to this across the continuum. So, you know, again, the point is you get more rehab at a less cost, and honestly, that's a pretty good definition of value if you really think about it. And it's wildly helpful when trying to justify the cost of post-hospital rehab to folks like you. From an investment standpoint, there's certainly a case as well. And so these cases can easily cost millions of dollars and require lifetime care. And so more than 10% of work comp costs are spent on cases 20 plus years old. So the old adage of the tail will kill you is certainly true. So here's a couple examples. So the first example, you have this idea of taking someone from 24-hour care to an assisted living level of care. These aren't hard and fast numbers, but in doing so, there's roughly a $30,000 to $60,000 per year savings. Here's a less extreme example. We deal with individuals all the time who come into our program with 24-hour care. And one of the first questions that we're trying to answer is, can we decrease that level of care? And going from 24 hours to 22 hours of aid time, or even if we consider the amount of aid time that someone has, let's say it goes from 8 hours to 6 hours, that can add up to a pretty significant savings if you look at it over the course of a year. So the figure you see is simply by taking someone from, let's say, 8 hours to 6 hours of aid time. Over the course of the year, it can save, roughly $15,000. Along these lines, some of you might even be familiar with Joe Peduta. He has a widely read blog. If you haven't checked it out, I'd encourage you to do so. He talks quite a bit about the workers' comp industry. Now, granted, he's a bit of a pot stirrer, so take this for what it's worth, but he recently discussed a report related to long-term claim costs. It was a 12-page long report, but I'll go ahead and sum it up for you. He had 4 main takeaways, and one of those takeaways pertained exactly to what we're talking about today. Far too many claimants get far too much care in hospitals, he says, and they may well be better served in a less intensive and inpatient facility. Hospitals love workers' comp and is very profitable, and there are very few controls on length of stay. Now, that might be changing, of course, but the point is, and he's encouraging all payers to figure out how to use less hospital care. So at the end of the day, when we're talking about service delivery, a few other things to consider. Does the organization proactively communicate things like at their admissions process? Do they proactively communicate when problems arise, or maybe when the program isn't going as well as maybe we had hoped? Do they proactively update you on the status of medication changes, or even just the progress that the individual is making? And along those lines, how do they go about providing family support and training? This is a big piece, being able to incorporate the family into the program, whether the family is on site or off site. That again is an excuse. We have to figure out how to get the families involved, and the training should be taking place alongside their loved one in support from a clinician or some level of care staff along the way. Transportation services. This is one that how do folks get to the program, and how do folks leave the program from a transportation standpoint? There are many programs that farm this out, and there are other programs that actually provide it themselves. So it's just something else to consider. As far as outcomes go, consideration of outcomes data provides a pretty tangible way to determine the effectiveness of a program. And just one point of caution here, though, make sure you're comparing apples to apples when you're considering outcomes. It's not enough just to compare one or even a few pieces of data between programs without considering the population or the individuals served within the program. So among other things, we have to consider the severity and the type of injury to get the whole picture. To get the whole picture. So here's an example. If you're comparing a program who's really the go-to when it comes to complex injuries or more of those complex cases to another program who has a more conservative admissions practice, you might see a difference in the outcome data, and that's something to account for. At the very least, evidence-informed rehab is the industry standard. So the programs you're considering should be able to provide you relevant outcomes data, and it should be easy for you to understand. Here's another point of caution. I've seen it all too many times where you have a provider who's heavily focused on data collection. They hang their hats on the data, and they have mounds of paperwork regarding sleep hygiene, the number of recorded behavior outbursts, even some of the behavior modification strategies they've used. Respectfully, they spend more time collecting and analyzing data than they do implementing strategies to shape behavior and promote recovery. So, you know, collecting data is beneficial. I'm not arguing that, but it shouldn't be the cornerstone of the program. So, you know, make sure that there's a so what that follows this data. There should be some sort of interpretation to say, okay, here's what the data is telling us, and here's how the program is changing or will change as a result. Along these lines, a couple things to be thinking about. Clinical outcomes. You know, a few of the ones that we collect here at QLI, we you know, consider the Mayo Portland, the disability rating scale, the supervision rating scale. We look at the discharge disposition and location. We also utilize the Northwick Park dependency scale. So these are just a few that we use. There's certainly more out there. But regardless, you know, as I mentioned, make sure that you're asking these questions and that the program can provide you some of these resources to compare. A couple other points, you know, length of stay. You know, I think this is a tricky topic. Certainly, a length of stay that is within reason is the sign of an effective program, but this isn't always the case. So keeping length of stay down simply to boost national ratings is poor practice. And I think we often see this in the hospital setting, particularly, but it can be at the post-acute level as well. So I'm not saying we shouldn't consider it, but we need to make sure that we're not sacrificing quality and the long-term vision for someone simply to keep our lengths of stay down. And so I think this is just an area for you all to consider as an accountability tool, right? For us, we're able to predict length of stay pretty quickly upon admission, and we usually project that relatively early on. And it's definitely a nice opportunity for everyone involved to hold us accountable. At the same time, this changes, and there are variables that we can't always account for. And at times, the length of stay is extended for a good reason, and we simply have to make sure we're thinking rationally about this and taking things on an individualized basis. One other thing to consider from a discharge disposition standpoint, sometimes you will get some resistance from acute rehab hospitals about discharging someone to a location other than home. And again, this goes or could be a piece of their satisfaction and their outcomes data that they're considering. One thing that we've done here is work to communicate that we are considered a community-based setting. And so that actually looks favorably on the hospital's outcome data. And so we've been able to have some more open dialogue about that. And so that's also something else to keep in mind. All right, when it comes to aptitude, you know, how do you spot a competent post-acute program that's able to deliver outcomes and therapy that are a step up? You know, that's a really good question. And you may be surprised that I'm not suggesting you look for the organization with the best medical director or even the one with the most neuropsychologists or clinicians. I'm not saying these aren't important, and there's certainly nice perks, but they don't matter if you don't have a healthy culture and a healthy team that makes the most out of the expertise. And so one point of consideration is that, you know, the clinical program is only as good as the culture. And a company who has engaged their team members to make sure that they are happy and they're in a positive environment is something that's really, really important to an outcome across the board. And so even if you don't adopt my vision for what a post-acute rehabilitation program should look like, I think it's safe to assume that we're all under pressure to achieve really good outcomes faster, and with fewer resources. And so at the end of the day, employees need to perform their very best every single day. And, you know, this is how we make that happen. I think it's just common sense, right? Creating an environment where your clients can thrive requires us to create an environment where our employees can thrive. Real quick, a story about Ted Williams. And if you don't know who Ted Williams is, he's arguably one of the purest hitters in baseball. And he's the last person to cross the magic 400 batting average barrier. And if you're not familiar with baseball, this is a pretty big deal. So even though he failed at getting a hit 60% of the time, this is really considered a pretty substantial feat in the world of baseball. So how did he do it? Well, we can really learn quite a bit about his decision making throughout this process from an idea he actually took from another player, right? And what he understood was that it's important to improve the odds of making good decisions in relation to our circle of competence. And so in the terms of what we're talking about today, our circle of competence is everything from what do we know about the service delivery? We've already talked about the outcomes of certain programs. We've also talked about the expertise, and where this leads with expertise is things like, is the program specialized with the diagnosis as well as the complexity of the cases that we're dealing with? And do they have the clinical offerings and expertise available to manage these types of cases? And so, looking for things like, a medical director who has experience with workers' comp, a medical director who has experience with the specific diagnoses that we're serving, and then clinicians who have either the certifications and or the experience that can carry out a complex program. Beyond that, I think we also have to look at the direct care staff level. And again, an example from QLI, we really see these folks as some of the most important players on our team. Granted, they aren't always the ones with the highest level of education. They typically don't have degrees. At the same time, they are the front lines for the individuals that we serve. And so they have the biggest opportunity to make an impact. Not only during the hours of 8 to 5, but also on the weekends and on the evenings when families are here. And so we spend a lot of time engaging them and training them on clinical practices, as well as more simple things like customer service and social skills and how do you introduce yourself to someone. So they're a big deal when it comes to the success of a program. We haven't talked about this a ton, but it goes back to this idea of being effective and efficient. And for us, we utilize that relationship between our clinicians and our direct care staff to provide rehab from the time someone gets up to the time they go to bed. And if we don't have that relationship pretty tight, that's not going to happen. And that kind of trickles down to the last point from a leadership standpoint. If there's been a significant change in leadership or there's some instability there, that's a word of caution in my mind. The leadership from the program should be pretty well entrenched in some of the day-to-day operations, as well as at a high-level decision-making standpoint. And so, taking all of these into account really helps us understand what is the program that you're using's circle of competence. Are they competent across the board in order to take care of the individuals that they need to take care of? And so, kind of getting towards the last point that we're going to talk about are resources. And admittedly, I've changed my view on this over the last couple of years. I still wholeheartedly believe that, beautiful buildings, pristine residential facilities, and the best rehab technology are only as good as the individuals that are available to staff the buildings and run the equipment, right? This goes back to the culture and the level of expertise. But I think I've begun to appreciate and put more stock into this idea that having resources available in addition to what the facility looks like and feels like is a big deal. And I emphasize what the facility feels like for a reason. At QLI, the best way for us to help someone understand who we are and what we do is to have them visit our campus. This isn't always possible, and so we've had to get really creative, but there's definitely no substitute for someone seeing our facility or any other facility for that matter with their own eyes. I'll tell you that we work really hard to describe our program in great detail, but there's definitely an intangible feeling you get when you drive onto our campus. And I think there's an intangible feeling that you get when you walk into a hospital or any other facility. You can just feel whether or not it's the right place to be. You can just feel whether or not it's going to be a good fit or a good match. And so the point is, if you can have everything we've mentioned up to this point, and have access to the best resources, I think it's a win-win. So don't ignore this, but don't put all of your stock into it. So of the few things I've listed thus far, a clean, safe environment, I would say, is usually the one that's pretty easily achieved. It's definitely more regulated than some of the other things that we're going to talk about. And again, that's pretty common sense. The rehab technology and therapeutic resources, I believe, are a whole different animal. It's rare to find the cutting edge rehab technology at the inpatient and post-hospital level. It may be available on a more outpatient basis, but by now I hope you understand there's a big difference between a post-acute level rehabilitation program and even an outpatient program. I will say you can definitely find rehab technology at a level beyond the acute rehab program, but it's often tied somehow to an acute rehab program. So, I think you should be looking for and expecting many of these programs to, have these resources available. Sorry, I'm having some technical difficulties here. All right. So the point is, don't ignore the bricks and mortar. Rehab technology, therapeutic resources, and the clean and safe environment are simply icing on the cake, if you're considering, all aspects of a program. A couple other considerations. Candidly, one of the big things we get all the time, because we're considered a center of excellence, is geography. The fact that folks have to travel to Omaha is something that we deal with all the time. And so, really what you're comparing is this idea that you have either one location and it's considered a center of excellence, or you have multiple locations. And there's pros and cons to both, and at the end of the day, it's something that we have to figure out what is most valuable to the individuals who are making those decisions. I will say that, having multiple locations, I would be considering things like, well, where are their clinicians spending most of their time? Where is their expertise spread out amongst all of those locations? When was that location opened in comparison to kind of that more of a headquarters type of location? If convenience is really a big factor, yeah, certainly those places that have multiple locations are going to have a leg up on the facility that only has one. With that being said, family housing is a nice option to counteract this idea of having to travel to get rehab. And so, do they have family housing? What's the cost of that? As an example, at QLI, we do have a nominal cost, but it's a suggested donation. And so for families who can't afford that, it's definitely something that's still available. And it's a quite a resource. And it even provides some opportunity for these families to go through some healing and have a support system in a more organic fashion. The continuum of care, is it simply a post-acute program? Do they have an assisted living level of care? Do they have more of a skilled nursing level of care? And do they transition into a day program? If you remember back to those transitions that we talked about, if you can find a facility that does offer a continuum of care, sometimes those transitions are a bit easier to manage. And so it's definitely a consideration, especially if you're considering the long-term road of the individuals you're serving. Medical oversight, what is the experience of the medical director, and is he on campus or off campus? How frequently is he on campus? And same thing for the clinicians, like I've already mentioned. Is the therapist employed by the organization, or are they contracted? In my opinion, there's a big difference there. Someone who's contracted probably isn't going to be as ingrained into the culture as someone who's actually employed by the organization and lives and breathes the day-to-day operations. And so it all comes back to that culture piece, and this is a component of that. Clinical research, at this level, again, there's a lot of data being collected. I don't know that there's a lot of research that is giving us the so what. And so if you can find a program that is collaborative, maybe with some of those other hospitals that are doing a lot of research, I think that's a nice option. And so it's definitely something else to consider. So in closing, I want to end with a little bit of an activity. So I want you to consider the very most important person or persons in your life. This could be a beloved grandmother, a spouse, or even your children, or a close relative. But at the end of the day, I want you to think of someone you love with all of your heart. And I want you to bring that person to your mind. At the end of the day, my hope is that we can treat the injured workers and their families just like this very most important person to you. If we could just help one more person, 10 more people, or even 100 more people, I would ask you, how would you behave? Would it be the same as you're behaving today? Or in fact, would you handle each decision, each interaction, and each meeting with these individuals differently? How would you approach your work each day? How would you approach getting out of bed and going to work, your drive to work, and then even some of the meetings you have throughout your day? And do you really believe that you have an impact, have the ability to significantly impact someone's life from a long-term standpoint? So there's an orchestra conductor who recounts one of his most powerful realizations. He goes on to explain that as a conductor of an orchestra, he doesn't make a sound. His picture might appear on the front of the CD, but at the end of the day, the conductor doesn't make a sound. He depends for his power on his ability to make other people feel powerful. It changed everything for him when he realized this. It was totally life-changing when he realized his job was to awaken possibility in other people. Of course, he wanted to know whether or not he was effective. And, he judges his effectiveness based on what someone's eyes look like. And he says, if their eyes are shining, you're doing it. If they're not shining, you have to ask a question. This is the question. Who am I being that the person's eyes are not shining? So it's only appropriate that we ask this question as we prepare to sign off today. Who are we being as we go back out into the world? Do you approach every situation with your most important person in mind? Shining eyes may be a perfect measuring stick for you, but one way we measure impact and success at QLI is through Christmas cards. If one of our employees gets a Christmas card from a current or former resident, to us, this is an indication that they have built a deep relationship based on trust and respect. It's more than just being liked. You gain respect in many ways, including listening, challenging, advocating, coaching, and counseling, to name a few. And everyone we interact with deserves that. So keeping this in mind, I challenge you to never let an opportunity for someone to get the best pass you by. Be brave and bold enough and influence them to make the best decision about the next steps in their care. Thank you.